let's start with cataracts. This is chapter 46, page 958. As stated here, cataracts is one of the most common eye disorders. The nature is clouding of your lens. Okay, that will cause, of course, like there will be obstruction in your field of vision. These are the common causes or risk factors: exposure to UV light, advanced age, family history, race, ethnicity, and diabetes and other chronic conditions. The rest are obesity, elevated BP, smoking, alcoholism, or other environmental factors, like if you're exposed to certain substances. But the most common, of course, is aging. So age-related cataracts are the most common types. Please read the pathophysiology on your own. I'm not really testing that. However, you do have questions on the exam on signs and symptoms. These are the various signs and symptoms the patient may complain of. Management: there are no eye drops to treat cataracts. The only treatment is surgery, so we will have to remove the lens. Okay, there's no cleaning medication. You cannot clear the opacity of the lens. They're pretty much gone. Okay, so if you intend to improve your vision, then the lens have to be removed. So you can already guess what are the questions on surgery. So again, I never test, or you will never really get tested on the procedure itself. However, the questions will be on pre and especially post-procedure nursing care. Please also read what the therapy will be. If the patient, because usually they put in a replacement lens after cataract surgery. It's called cataractectomy. It's usually replaced because, of course, the function of the lens is to protect your eye, correct? So they usually put a plastic lens implant to replace it. However, if they can't have that, and here is your protection, okay, the patient will have to be given corrective eyeglasses or contact lenses, because you have no, if there is no lens implant. It's pretty successful. Again, the questions won't be about the surgical procedure, but rather what your responsibilities are and what you teach the patient to do, especially after surgery. I mentioned earlier that there will be no eye drops involved to treat the cataract. However, the patient will be receiving eye drops before and after surgery. We will discuss the administration of eye drops because that's on the exam. Plus, patients need to be taught how to properly and safely administer eye drops. So it will be either the patient or the caregiver administering these eye drops, or even the nurses also. You may be taking it for granted and don't really know how to administer eye drops. There will be tables like this all over the chapter. You've already seen them. They simply explain what the rationales are for the signs and symptoms for each disease. So I'll leave you responsible for these. This will answer questions on how you're explaining the reason for, if let's say the patient asks you, why do I have this, why do I have that, these are your answers. These are your nursing care. So again, the patient with cataract will only undergo surgery. There is no other medication to treat it. These are the eye drops that I mentioned earlier. So this will be given before surgery, and the patient will also have eye drops also post surgery, because of course you'll need antibiotic eye drops as well. So it will continue after surgery. So these are the two that are given before surgery for obvious reasons. And the activities that will increase intraocular pressure are discussed in detail on the next disorder under glaucoma, so I'll discuss these later. But please, well, these will be the same anyway, so they will be discussed again under glaucoma, but these are specifically for cataract surgery. And again, they will share nursing care, because again, the intraocular pressure increase is common, especially if you have a treatment that involves surgery. Please read your teaching on your own. The patient, especially after surgery, will need these. Okay. And also the patient, of course, has decreased vision, not only before surgery but also immediately after surgery. Patient will be wearing eye patches. Okay, we don't want rapid eye movement, so it will have to be covered and protected from UV ray, especially if they did not have lens implant. Okay, so this safety alert here applies to all patients having surgery. Although this is entitled having cataract surgery, again, this does not apply only to a patient with cataracts who underwent cataract surgery. There will be no other repetition of this chart as we discuss surgical management for the other disorders, like for glaucoma, for instance, and retinal detachment and retinal tears later, or even for macular degeneration, because that disorder also involves laser surgery. Okay, so during the first 24 to 48 hours following cataract surgery, or you can remove cataract surgery there, and then that will again apply to all eye surgeries. So these are simple to read, so please read them on your own. I'll proceed now with glaucoma. Now for glaucoma, there are various types here. The normal intraocular pressure is between 10 and 21 millimeters of mercury. That number is found on chapter 40. What is this? This is 40. If this is 46, then it'll be in chapter 45. Okay, if you're looking for the normal intraocular pressure range. So if it's between 10 and 21, of course, an IOP of more than 21, beginning in 22, is already high. So the problem in glaucoma is increased intraocular pressure. There are various reasons we'll discuss shortly under risk factors and causes. The problem if your intraocular pressure is increased is it's inside a enclosed space. The eyeball doesn't really have much compliance, meaning it can't allow for just like the skull. Okay, the skull has a limited space. It can only allow for minor increases in volume and pressure inside it. So same thing within the eyeball. Okay, you can't really add volume in it. So the problem here is there are two. What will increase intraocular pressure is one, there is inadequate drainage of aqueous humor. Aqueous humor is that fluid inside the eyeball which is constantly circulating, giving your eyeball its normal shape. Or it can also be caused by an overproduction of aqueous humor. Again, an inadequate draining of the aqueous humor. And I'll show you a short video displaying the no, you know what, let's do it right now. I'll just show you part of the video. Right, so this is your pupil, this is your lens, and this is your eyeball. There's a network here called trabecular meshwork, and there are canals here. So think of it as a winding river on both. We're only showing one side, so there will be another network here, another network of canals, drainage canals on the other side, other corner of the eye. So this is where your aqueous humor is, because this is your eyeball. So they drain here in this direction, and there are two pathways here. Number one is the trabecular outflow, which accounts for most of it, about 85%, and there's a tiny canal here called the uveoscleral pathway. So 85% here, and then a little bit, 15% also here. And let's see what happens. So this is just the normal part. Okay, so I'm just demonstrating how aqueous humor is constantly being produced and drained at the same time. So as long as that is occurring, then you have normal intraocular pressure. Now the problem again results if either there's inadequate drainage of that aqueous humor, causing a buildup of that aqueous humor and increased volume, increasing pressure, or there is a overproduction of aqueous humor, or if you have both, then that will be worse. These are the risk factors for glaucoma. Please read them on your own. I'll actually go back. No need. Okay, so I'll discuss a few. For instance, myopia. Myopia is nearsightedness. When you have nearsightedness, this one will elongate the shape of the eyeball. Instead of being rounded, it becomes more elongated. That will of course increase pressure, obviously, inside the eyeball, and not to mention also this can even cause some retinal detachment. So we'll discuss that later under retinal detachment. Prolonged steroid use. So this would be people who have either inflammatory or autoimmune disorders, or like lupus, for instance, or rheumatoid arthritis, which we discussed already. Because long-term steroid use, of course, increases fluid retention, fluid buildup, and that will also include volume of aqueous humor in the eyeball. So that will increase IOP. The rest are these. There are, like I already said, there are a few types of glaucoma. Most common is primary open-angle glaucoma. This one is slow in onset, but because it's slow in onset, the damage will have already been done by the time the patient is diagnosed, so there will be considerable loss of vision already. The other one, which is acute onset, or called angle closure glaucoma, this is also called acute glaucoma because the onset is quick. Okay, so this will arise within a few hours. Okay, the symptoms come on really fast, and you can already assume that this is an emergency. This one, the acute form of glaucoma, will be must be treated quickly. These are the signs and symptoms, which will be described again or mentioned again under clinical manifestations. I already mentioned that this is a medical emergency, okay, requiring surgical intervention. Eye drops is the only treatment. Anyway, I'll discuss these under management. Normal tension glaucoma. As you can see here, there's really a very mild rise. Technically 12 is actually normal, because the normal range again is between 10 and 21. So this is not really that high. Okay, and as explained here, it's not really understood because it's not really a drastic increase in intraocular pressure, but yet this type of glaucoma still leads to destruction or damage to the optic nerve. For the other types of glaucoma, the primary angle and acute angle glaucoma, of course, it makes sense, because if your intraocular pressure is high, then of course that will press on the nerves and blood supply of the retina and the macula, so that will damage your nerves, and including the optic nerve. Secondary glaucoma, of course, this is due to treatment for another disorder. We mentioned earlier the chronic corticosteroid use. That's an example of secondary glaucoma. Pediatric glaucoma, we will skip. Obviously, that's only for peds, and I'm only responsible for adults. Manifestations, regardless of the type of glaucoma, except of course for acute angle glaucoma, there is loss of peripheral vision. So for normal tension, primary open angle glaucoma and secondary glaucoma all have loss of peripheral vision, and as a result that you'll have tunnel vision, because again you can't see from your periphery, so you'll have only central vision remaining, and then eventually this will lead to blindness. Acute glaucoma, on the other hand, is again acute onset, so you will see these. You'll see the rationales later. There will be again a table underneath this later in the page, explaining why these manifestations occur. Medical management. This is better prevented easily, actually, by regular eye examinations. So for those who are wearing glasses, so every time you have your eyes checked yearly, which is advisable, part of the routine examinations is to measure IOP. This can actually obviously occur as early as in infancy. Already mentioned here, there is a pediatric form of glaucoma, so actually all age groups are affected by glaucoma. So the only way, there is no cure. All you can do is just control the intraocular pressure using eye drops, and these eye drops of course have to be taken for life. May not sound very hard for you, but think of the pediatric patient, especially teenagers. That will be a challenge, because it's not cool to be putting on eye drops. Okay, so they may not comply with the treatment, and that's usually the reason for early blindness, because they do not comply with the therapy. Remember that every time the intraocular pressure increases, it will compress on the fragile nerves and blood vessels inside the eye, so that will cause damage, and every time that happens, so there will be loss of vision, and that will increase over the years. So yeah, that will result in blindness. There are surgical options, but again, they're not, as stated here, they're not effective in treating the disease. Okay, again, there's no cure for glaucoma, but again, it will, all these measures, whether it's eye drops or the surgery, is just to preserve vision, okay, to prevent it from getting worse. We have a variety of medications. So if you remember seizure, the seizure chapter, we had several seizure medications. Here also in glaucoma, we have plenty of eye drops. So all of them are testable, because all of them are found in clinical. Patients will be on 2, 3, or even sometimes 4 eye drops. The The trick to remember this is they all sound the same. Look at prostaglandin in medications. Prostaglandin, of course, is a vasodilator, so you can already say you already know what this drug does. This is a vasodilator. So how does vasodilator drugs help glaucoma? So because they are smooth muscle dilators, blood vessel dilators, so they will of course dilate the meshwork, the trabecular meshwork, increasing the outflow of aqueous humor. Beta blockers also have some vasodilating effects, but most of its effects, of course, is not only decreasing heart rate and blood pressure, but they do so by inhibiting the effects of epinephrine, which is, of course, increased heart rate and vasoconstriction. So if they are blocking those, they will have the opposite effect. So they'll decrease heart rate and also cause vasodilation. Same thing with alpha antagonists. This is also the same as ARBs. So these are the drugs. Here are the mechanisms by how they work, and then just go down the list. Miotics are pupil constrictors. Of course, if you look here now, I'll show you the video again. So how do these drugs work? So if you constrict the pupil, if this pupil is constricted, then of course that will increase the diameter or the outflow there of aqueous humor. Okay, again, this one, latanoprost, is a prostaglandin type drug, so that will also cause vasodilation. And the same for timolol, which is your beta blocker. Surgery. So you've heard of laser surgery. Again, the questions here on the exam will be on pre and post-op care after eye surgery. And what do you follow again? Because there is no mention of specific nursing care here. It will be the same nursing care as with mentioned under cataract surgery. Here is the rationale for the signs and symptoms I mentioned earlier. Read that on your own. Okay, so for eye drop installation, we have them in detail here, safety alert. So this is absolutely testable. Again, we need to tell the patient, we need to teach them, and also the caregiver. If they're not able to do this, then it has to be the caregiver. Most importantly, with the teaching, teach them that it's really important to comply with the eye drops, because that's the only thing that will maintain their vision, keep it from getting worse. Again, the key here is to keep intraocular pressure within normal every day as much as possible to prevent eye damage and, of course, loss of vision. Now, as far as activity restrictions they mentioned here, what was mentioned under cataract was, I believe it was bending over, bearing down or Valsalva maneuver, coughing, sneezing, even sexual intercourse, actually, because all these activities require the person to take a deep breath and hold it, right? If you picture yourself or simulate coughing, for instance, or sneezing, or before you lift something heavy, or before you bear down to give birth to a big turd, or any other similar activity. So it requires you to take a deep breath, hold it, and then do the activity, right? You can't really cough without taking a breath in first, right? That's why people who choke cannot cough, because they can't take in a breath, if that makes sense. Alright, let's proceed with macular degeneration. There are two types of macular degeneration. There's a dry and a wet. The dry type can convert into wet, but the wet cannot become dry. So this one, unlike glaucoma, wherein it was a loss of peripheral vision, this one is a loss of central vision because this involves the macula. Macula, of course, is the part of your eye that is responsible for central vision. These are your risk factors: hypertension, high cholesterol, obesity, smoking, and age. Of course, dry macular degeneration is caused by aging, similar to cataracts. Okay, so let's talk about dry. So dry is simply degeneration. So this is that's why it's age related. Okay, because you just got old. Okay, it's an old eye. The macula degenerates. These are how the doctor makes a diagnosis. Okay, so you have deposits there called drusen bodies on the macula. I'm not testing the faces because it's not really necessary. Here is a comparison between wet and dry. So dry obviously has 3 stages, and then wet only 1. The mechanism is different. Okay, I already mentioned that dry macular degeneration is simply degeneration, aging of the macula, whereas the wet type doesn't only occur in advanced stage. Okay, it can also occur in younger people. So the wet type is caused by the growth, an abnormal growth of new blood vessels in the macula. The problem is these blood vessels are fragile and leaky. Okay, so here they are fragile and leaky. Okay, so this is now what causes the degeneration of the macula. Okay, so there's poor blood supply now because not only are they fragile, but they're also leaky. Manifestations are similar. However, there are few slight differences here. Treatment. There is no treatment for dry macular degeneration. You can only slow it down. This is the current recommendation. Vitamin C, vitamin E, beta-carotene, and copper. So this is called the ARID formula. Bausch and Lomb produces this. They sell it in this combination. These are the vitamins that they contain. Again, it does not cure dry macular degeneration. It only slows the progression. That's it. In wet type, there are a few options. We have photodynamic therapy, and this is the drug that they use. This is a light activated medication. Again, go back to the pathophysiology. So since the wet type is caused by an overgrowth of new fragile and leaky blood vessels, so this will destroy those blood vessels. Again, it doesn't really cure, because once the vision is lost, they cannot be regained. However, if you stop it early, then that will drastically improve vision. Another is this one, the injection of a vascular endothelial growth factor. So this is a drug that will suppress the growth of these abnormal blood vessels, causing the wet type of macular degeneration. And here's surgery again. So we have laser surgery. Again, the pre and post-op will be the same. We already discussed this under cataract surgery. Here's explanation again between the the two types of macular degeneration and their rationale for the resulting signs and symptoms. Okay, and then as with any other patient with visual disorders, our nursing care always includes safety, okay, because they have visual impairment. We proceed with retinal detachment, and this should be the last of the eye disorders. Retinal detachment. As stated here, this will cause permanent vision loss. So where is the retina? Okay, so here's your macula, and this is the retina. So this is the part of the eye where vision is reflected. So light hits your lens, and it's refracted depending on the eye angle. So it will be reflected against the retina. Then the retina, of course, is attached to the optic nerve, and that will interpret what you're seeing, and then it's transported to the brain, and then you can recognize what you're seeing. So it should be, for it to work, it should be attached against the eyeball. Okay, it cannot be detached like this, because of course your vision will now be distorted if it's not attached to the eyeball. If it's crooked like that, and there's no way you can see properly. So please read that. I just gave you a rough description of what the retina does. There's manifestations mentioned here, but the complete manifestations will be under clinical manifestations. These are the common causes. So one is trauma. Take note that cataract surgery is traumatic, so that's why this can cause retinal detachment, possibly. Or other trauma, like eye injuries, for instance. I already mentioned myopia can also cause retinal detachment. Other causes are these disorders here. Alright, I am not testing the mechanisms, because really regardless of how the retina detached, the resulting manifestations and the treatment is the same, so there's no need to really test that. So here are your patient's complaints. The patient will have light flashes or floaters in the visual field. Those floaters could be fragments of red blood cells, because there will be bleeding involved here as the retina detaches. And so what the patient's really seeing are floating red blood cells. Okay. Medical and surgical management. There are various means. Again, I'm not testing how the surgery is done. It's only to pre and post-op. I'll just briefly describe some. So these all involve the creation of an inflammatory response and scarring, which follows the inflammatory response, which will reattach the retina against the eyeball. If there are tears, of course they will do laser to seal the tear. So that one's simple here. They can either freeze them or use laser to seal off the tear. The detachment, though, is more extensive. Okay, the most common procedure is scleral buckling. Here is your scleral buckling. Now don't ask me how they put this in here, because obviously, I mean, how do you put a silicone rubber band around the eyeball? Of course, that will be done surgically. Now I refuse to show a video because I cannot stand watching it. It's too violent for me. Anyway, the idea is, because the retina is detached, right? So here, that's a detached retina. So they'll use a silicone rubber band. It's not really a rubber band, because this is not it's not stretchy. Okay, the correct term should be a silicone band. Okay, but it's not a rubber band. Okay, it's not stretchy. So this one will, it's a buckle, no, like your belt. So they put it around the eyeball, reattaching the retina. So again, just imagine how they put that in there. So this is your eye socket here. So they'll have to use several instruments in order to insert this buckle around the eyeball. The other one is called retinal pyopexy. So this procedure is the injection of an air bubble at the site of the tear. Now the doctor, of course, has to see he has to locate where the tear is and then put the air bubble there. Now, how does that work? Now this bubble is called SF6. I think it stands for sulfur hexafluoride. Anyway, the idea is this gas bubble is denser. It's not heavy, it's dense. Okay, there's a difference between density and weight. So density in physics is about mass and volume, and then weight is about mass and gravity. So imagine a gas that is denser than air, meaning compared to atmospheric air, it has more mass and volume. So of course that will be greater in density than atmospheric air, so it has the ability to press this. So the doctor injects the air bubble, the gas bubble, and then the gas bubble will press the retina back and then help reattach it to the eyeball. Okay, of course there are instructions here because of course it's an air bubble, it's going to move around, right? So you need to tell the patient, actually the doctor gives them instructions and you have to reinforce that. Where is it? Pneumatic, here it is. Okay, pneumatic retinopexy. So this is the here's your instruction. So you teach the patient this of course before surgery, so that and then you reinforce it post-op. So we need the gas bubble to be in a certain position. So that's why the patient will be told, it doesn't really have to be these specific instructions. I mean, the doctor will tell them which side to hold their head and at what angle. But regardless, the patient must not sleep on their back, okay, during this time. This is not forever. Okay, this just be a few days, probably up to a week. So the patient needs to keep their head upright or keep their head sideways, okay, at a certain angle, again depending on where the tear is. I don't know if you can picture that. So if this is on the more on the right side of the eyeball, for instance, so that means the patient has to tilt their head toward the left, so that way the gas bubble will press against the right side, if you can imagine that. All right, so that's the most important thing if they perform this procedure here. And we will not remove the gas. The gas bubble will just dissipate after 2 to 8 weeks. But again, on top of those though, remember again the post-op care you learned under cataract surgery. Those things still apply for retinal detachment surgeries. And moreover here, again, as with post-op and cataract surgery, we don't want any rapid eye movement again, so that's why we cover both eyes loosely. And again, we teach them to avoid activities that increase IOP. We already mentioned examples. Okay, so here they are again. They are mentioned again. All right, that ends chapter 46.